right, I think we'll go ahead and get started as people are still joining. I have a few introductory remarks, and then we'll have our presentation for today's AV Institute for Global Health seminar. My name is Dr. Rob Murphy. I'm the Executive Director for the AV Institute for Global Health and the John Philip Fair Professor of Infectious Diseases and also Biomedical Engineering here at Northwestern. Thank you for taking the time to join us this afternoon for our latest installment of the AV Institute for Global Health seminar series. The title for today, as you can see on the slide here, is Pediatric Hydrocephalus and Spina Bifida in Zambia. Please take a moment to follow us on LinkedIn and Facebook, as well as Blue Sky and Instagram at hashtag FSM Global Health. In addition, we welcome you to become an Institute member, a process that takes at least 30 seconds. Where you then will receive access to specialized resources and services that support research infrastructure. And for more information, please visit our website at, it's very simple, globalhealth.northwestern.edu/members. So today we are thrilled to host Rebecca Reynolds, MD, at today's seminar. Dr. Reynolds is an assistant professor of neurosurgery and pediatrics at the University of Iowa Healthcare. As a neurosurgery resident, she completed an NIH Fogarty Global Health Fellowship in Lusaka, Zambia, and now directs a multidisciplinary research program studying pediatric hydrocephalus and spina bifida throughout Zambia. At the University of Iowa, she currently serves as the medical director of the UI Neurosurgery Clinic and on the Stead Family Children's Hospital Surgical Executive Committee. She specializes in the clinical care of children with brain and spine concerns, specifically neural tube defects, spasticity, and craniosynostosis. We welcome you today at any time during the presentation to put a question in the Q&A feature located at the bottom of your screen. And don't use the chat, please. Use the Q&A feature. And you can do that at any particular time during it. Following this, Dr. Reynolds' presentation, we'll have a Q&A session run by Dr. Roxana Garcia. So, Rebecca, take it away. The floor is yours. Thank you very much for joining us today.
Thank you, Dr. Murphy, for the kind introduction, and everyone for your opportunity to share a little bit about what I've been up to, and I hope you have an opportunity to learn something today. So, where this really comes from is something, as Dr. Murphy alluded to, an introduction into global health from a neurosurgical standpoint is something that I really began to experience as a resident, and I completed my neurosurgery residency at Vanderbilt. And so this was not something that's been, ever since the beginning of time that I've been aware that I've had a huge passion for, but it's something that's really evolved into a labor of love. And so, we're going to talk today about Zambia. You may or may not have heard of the country of Zambia. It's in sub-Saharan Africa, on the southern part of the African continent overall. And really kind of the outline today is fairly straightforward. I'm going to be talking about, this concept of global neurosurgery within the greater field of global health as a whole. Why Zambia, why spina bifida, right? And a little bit about how I've approached it over time, and then just a few concluding remarks from there. So with respect to global neurosurgery, right, it's similar to the fundamentals of global health, right? We're increasing access to quality neurosurgical care. Purpose is to try to address preventable disability and death, and how can we provide safe surgery? And so, why don't countries have safe surgery? So this is something that I will provide the context as part of my Fogarty Fellowship year. That was something where my husband, my infant daughter at the time, and I moved during my neurosurgery residency to Lusaka. And this was the year before the COVID pandemic broke out. And so there was a lot of change and things going on partway through that year that had an impact on that. But I will say the photos from today are pictures by and large that I've taken over the years of being there. And so really this was, one day driving home from work, and this is what you see in Zambia, right? Pictures like this. This is not always something you see in the US, but we do from time to time. There, it's everywhere. So why don't countries have safe surgery? Well, it's timely access. So the median distance to a hospital in low and middle income countries, as you can see, is much higher than high income countries. That's not to say that we don't have these problems in the United States and elsewhere. in high income settings, but it's very rampant in low and middle income settings. And then you have things like where's the seat belts, right? Where's our safe mode of transport there? And so you also have some risk factors that lead to a higher incidence and potentially more severe injury patterns as a result when patients present. Um, why don't countries have safe surgery, right? So we've talked about timely access, distance is a factor, available specialists is another one. So this is something that was published by one of my colleagues previously that looked at neurosurgeons per capita worldwide, right? Red is not a lot, green is more. So what we can see really is, right, the continent of Africa as well as Southeast Asia region also has a difficulty with the ratio of neurosurgeons to potential patient population. And so beyond available specialists, we talk about supplies. So this was a colleague who's based out of Rwanda who put this paper together. And, she was looking at the access available within her hospital system. And there's much that we take for granted here in the medical field, right? In the United States, we have definitely pinch points, absolutely. But is it something typically as basic as a CT scan? No, it may be that we don't have 4 CT scanners running, we only have 2 that day, so there's a delay. But what about the presence of a CT scan versus no CT scan, right? And so CT scan, for example, here is something that was fairly present, but as you get more detailed into things that we use commonly in neurosurgery, microscopes, endoscopes, things like that, it becomes rarer and rarer. And then what about the basic things, right? So in the survey, right, they were looking at running water, oxygen, electricity, a blood bank. Again, a blood bank is a fundamental part of a safe surgical practice. And if 73% don't have access to a blood bank, gosh, where do we stand there? And then ultimately, cost is a big factor, and that's not something that's unique to low and middle income settings either. So, that's a little bit about global neurosurgery as a whole, the concepts, the problems that we face across the world. Kind of narrowing in on my project. Why Africa? Why did Zambia? How did I end up there? It's something that, where is this passion coming from? So when you think about Africa, right, it often can be a misnomer because you say, okay, I'm going to Africa. And you're like, well, you don't say I'm going to North America when you say you're going to the United States, right? You say you're going to the United States, or you're going to a single state, right? I'm going to Iowa, or I'm going to Illinois. So Africa is commonly, it's a misnomer in a sense to say, okay, there's actually, depending on the day, but there's roughly, around 50 to 60 countries on the continent of Africa. And each one is a little bit different. But in Zambia, right, there's this, when you think about Africa, right, there are the thatch roofs and the village huts that you see. This was driving along on the road one day. Some people may think about the Lion King, right? That's something that the quintessential safari that is stereotypical Africa, right? You think about the animals and how the animals there are very different here, right? So there, this is the backyard of our backyard one day, right? And you have a zebra in your backyard. Is that something you would see in the United States? No, right? We would have deer here or other different things that would be an anomaly, right? Throughout much of Africa. Mount Kilimanjaro is beautiful, right? The scenery is gorgeous, right? The apartheid is something that was very much a big part of South Africa's history, and something that may come to mind when someone mentions Africa as a whole. But what is Africa truly like on the ground? And this is something that I can really speak to Zambia as we narrow down in even more closely than Africa, right? It's beautiful. The wildflowers are gorgeous. This is a wildflower bouquet from there, right? The people are wonderful. This is, some of the kids in our neighborhood who we shared a soccer ball with, and we were going for walks. And it's lovely, truly, really, in scenery as well as the people. They're innovative, right? And so these are 2 pictures just on the side of the road, right? Just because you don't have a car doesn't mean you can't get your goats to where they need to go. Doesn't mean you can't deliver, 50 dozen eggs to the store to be able to take it there. And so it's an incredibly smart, innovative country as a whole, really. So why Zambia, right? So we think about Africa as a whole. So this is where, the darker red you are, the less access to safe surgery that you have. And so the darkest red is the least access, right? It's the fewest number of neurosurgeons with the most number of patients. I think the current statistics are, especially from a pediatric standpoint, that, over 90% of the world's children live on the continent of Africa, right? And so I think it's something to that effect. That may not be the most recent statistics, but that's something that's been reported in the last 10 years or so. And so that's something to say, like there's an overwhelming number of the world's children that need access to care. And with that comes issues like spina bifida or hydrocephalus. And Zambia is what's at the tip of this arrow here and very much falls within that region that needs access to safe surgery. So Zambia is a country of about 20 million people. Its capital is Lusaka, which is the place that I lived when I was first starting on my global health journey about, I guess, six years ago now. It's in a fairly central location within the country as a whole. Narrowing down into hydrocephalus and spina bifida, really it becomes down to burden of disease. So within kind of how I think about global health and its intersection with neurosurgery, especially pediatric neurosurgery, is where is the biggest amount of potential for change to happen. When you're talking about lives saved in children, independence, going on to be able to hold a job or graduate from a education program. These are all things to take into consideration. And so, I'm going to show a smattering of charts here, and really the message is written very short here. There's a very high burden of hydrocephalus. There's a very high burden of spina bifida. The disease severity is worse in Africa and especially in Zambia, and many of the children go on to die. So, this is an example of hydrocephalus distribution across the continents. Red, right, is the highest number of patients that we see. When we look at truly the data, this is, one of the caveats and the limitations of the initial map here on the left is coloring countries completely in, but really, truthfully, do we have population level data for those countries? And I would say we don't. And so really what the true map of the African continent looks like, at least as of 10 years ago, was we have individual city level data, and we know that the incidence of spina bifida is high, but we truly don't. There's a lot of missing data across the country as a whole. And in order to be able to make change within global health research, you really have to understand the public health aspect and disease incidence and severity. And when you compare it to, countries across Europe, right, the incidence is different. This is very much old data, and I couldn't find anything newer. But really, we will look at neural tube defect deaths published by the WHO in 2012. Not only is there more disease, more children are dying from disease when you compare to countries like the United States, for example. And so really, this is something that's very much a glaring health disparity overall. So I keep mentioning spina bifida, and I wanted to make sure we had a level playing field today. So what is spina bifida, right? So it's a neural tube defect. This is an example of one of the children we care for. And you can see that essentially what happens is the nerve roots, which is this dark pink spot in the spinal cord, are born outside of the body. So you're missing a skin layer. And because of that, that child has a high susceptibility to death or other neurologic issues such as meningitis or central nervous system infection overall. And so spina bifida is something that is very prevalent in Zambia. It is still prevalent here in the United States, but it's something that typically is responded to folic acid in about 30% of cases. So when the CDC implemented folate fortification in the United States in the 1990s, where we started fortifying wheat bread products with folic acid, the incidence of spina bifida went down by about 30% in the United States, which was not as much as they initially thought it was going to, because the heavily controlled environments, it showed a decrease in spina bifida rates of 60 to 70%. So, the case of spina bifida, and the point I'm trying to make is it's unsolved. But right now, with where we're at, is the under 5 mortality rate, right, is much higher across all children in Zambia compared to the U.S. It's almost 8 to almost 10-fold higher, right? And when we look at myelomeningocele, which is another word for this one type of spina bifida that we look at, right, it's at least double in Zambia compared to the U.S. as well. And so these children have other comorbidities. One of the most common ones is hydrocephalus, which is why my work looks at, again, hydrocephalus and spina bifida. So then, to put a bow on it, what we're looking at is why make a big investment in spina bifida and hydrocephalus and in Zambia. And I think really this is kind of comes down to the philosophy. And in surgical world, a lot of what traditionally has been the approach to supporting, healthcare in other countries in ways that we know best, right, is surgeons we use our hands. It's right. I use it every day in my line of work. And performing surgery. And as we said earlier, many children don't have access to surgery. And so you could do a medical mission trip, you could operate like crazy and do 30 cases in a week. and then you leave and come back. And yes, there is some value absolutely in performing the surgery if there's nobody to do that. But what happens if there's a complication, right? What happens if there's a wound issue? What happens to that child as a result? And so who's going to care for that child when you're gone? So what we found is that there needs to be much more to it in this concept of global neurosurgery. And so this was a slide that I borrowed from one of the neurosurgeons that does a lot of global health work at one of my colleagues. And so really there's kind of three ways to do it in building over time, right? And the purpose is to encourage independence. So this is an example of a man stuck in a hole, right? And so the doctor can come by and say, okay, I'm going to help take care of you. I'm going to give you the pills and you need to take them. Like, okay, great. Like, are you going to save this man because he's going to get his medicine? Yes. But is the man ever going to be able to get out of the hole? No. Right? So then, okay, let's start talking about this land of knowledge. Here's the doctor comes in and says, okay, I'm going to help you get out of this pit, right? I'm going to toss you a rope and we're going to help you climb out, right? And so this is something that the man is going to be able to get out. Yes. But is he still dependent on the doctor to hand him a rope? Yes. So how do you get to a point where this family, right, in this example, is stuck in this hole and they don't need anybody standing outside the hole to help them, work independently and go on and thrive in life? And together, this is teaching, right? And so this is teaching that group to how to get yourselves and work together to get out of the hole. And so I think this is something that is, applicable across many solutions in life, and global neurosurgery is no exception to that. So we're going to talk a little bit now about how I have approached it, and starting a new career in global health and running a busy surgical practice here in the United States in the interim. So I should say that, the way my practice is set up now, that I have, a full-time pediatric neurosurgery practice, and a few weeks of the year I am located in Zambia. But I have a running research program with weekly lab meetings and a full-time research team that's based in Lusaka, who are Zambian. And so I think that's something that many of our students here at Iowa participate in the program. And so it's really grown into a collegial educational capacity building with respect to research and subsequently clinical care community as a whole. But really, one of the biggest things that stood out to me, and I know Northwestern has their own Fogarty fellowship program, which was different than Vanderbilt's when I participated, but this is one of the seminars. So if there's any trainees on the call today who are potentially considering a Fogarty fellowship, I cannot say enough good things about it. So, Jim Kim was the former leader of the World Bank. And one of the talks that we were received during that time was looking at the Jim Kim approach. And so I'm going to read this because I think this is probably one of, again, the biggest impacts that's had on my thought process about global health. So finance and macroeconomics are complicated, but you can actually learn them. The hardest thing to learn is mud between your toes, on the ground development work. You can't learn that quickly. You can't learn that through trips where you're treated like a head of state. You have to have kind of done that before. And so I think that's a really remarkable, very poignant point, right? Pretty smart people run the World Bank, so we'll say. So I think that, having moved to Zambia, moved my family there, working together, learning the culture, learning the environment is invaluable. And so that's something that's really made a positive impact about how I shape our program now and lead it. So there's 4 lessons that I'm going to go into a little bit more detail here on the next slide that I've learned about this process as a whole. Number 1 is get a foot in the door. This was the Fogarty Fellowship for me. So they hadn't had a neurosurgery resident participate in the Fogarty Fellowship prior to the year that I participated in it. And I was lucky enough to be able to participate in that with Dr. Roxana Garcia, who's among the audience today. And she and I really formed a very strong, research relationship during that year. And so the people you meet along the way are remarkable. And it really sets you up for a community and success in the future. So if there's anyone who's considering this fellowship or has further questions about it, I'm happy to talk more about it. But really, this was the opportunity that changed the trajectory of my course in medicine. Number 2, learn to work in a system not your own. So, one of the common issues that we face within surgery, and this may be true across other disciplines within medicine who are involved in global health, is to waltz in and say, this is how we do it in America, and therefore this is the way we should always do it. And everyone else needs to do the same thing. And so that's not, that's something that may not go over very well, depending on the environment that you're in. So these are some pictures of the hospital that we work on. It's a public hospital. It's a government system with nationalized healthcare in Zambia. And so that helps address some of the issues with access and cost of care because everything's subsidized. This is the neurosurgery clinic here, and it's just everybody lines up in the morning, and then they get seen as there's one appointment time, and then you get seen as things come. The last thing that I think about with systems is what are the healthcare beliefs? What are the beliefs that are common among families or patients there? And so this was an editorial that was published in the Lancet in 2014 that I want to, again, read just the short red box of it, because I think when we think about, as a neurosurgeon, the vast majority of my patients are children with disabilities. And so disability, specifically neuro-related disabilities, are something that are a very sensitive topic in the United States and in Africa. So it is, when we refer to disability, it is a punishment from God, witchcraft, the fault of the mother, reincarnation. These are all frequently stated causes for disability in children in Africa. Such false beliefs are deeply rooted in tradition and culture. In truth, most children with disabilities in Africa have been disabled by the sad predicaments that continue to haunt the continent: war, poverty, and inadequate access to health care. So with this in mind, we think about, okay, how can I potentially solve the problem, right? What is the problem? The problem is that, is there children who ultimately are born with a disability that didn't need to be born with a disability, right? Is this something that was preventable? Or is this a child that was born with a disability and didn't have adequate access to healthcare to be able to help them achieve independence or otherwise? You can think about money. And one of the residents that I worked with several years ago said this quote to me. His name is Arnold. And this is another thing, again, the experiences that shape us in our life. You can't keep giving money. You'll eventually run out of money, right? So this thought of, okay, I'm going to go over, I'm going to operate like crazy. Yes, that's going to have a short-term impact, but what about the long-term impact? Okay, I'm going to donate money. Do we need money? Does money make the world go round? Absolutely, right? So you can't do it without money. But money alone is something that's not necessarily going to change the trajectory, right? So, for example, right, there are countries with unrest, right? So this was a protest that happened in the time that I was in Lusaka, and this, changed the course of how we functioned for a few days, but was ultimately settled, right? The police system there is very challenging at times, and so do people carry, Coca-Cola and Fanta, which Fanta is a very popular drink there, with you to be able to say, okay, is this something that we need to be able to consider to, the police are asking for drinks, and do I give this instead of giving money, or am I going to have a ticket for whatever reason? And so, there's a lot that's going on behind the scenes there. And ultimately what it comes down to is this chart on the right that we see, right? What you want to have is be thinking about the breadth, right? And the commitment. So what is the breadth of your time, the breadth of what you're able to provide, and what level of commitment are you willing to give, right? Benevolent donation, money, does it make a difference? Yes. Is it narrow in scope? I guess it depends how much money you donate, but that's something to think about, right? But if you're able to donate money and you're also able to travel there to see what they're doing, that has a little bit wider impact. They meet the people where the money is coming from, right? Or you think about teaching. Okay, teaching is something that's absolutely going to have an impact. And the commitment, it takes a lot of time. But you're only going to impact necessarily the specific people at that point in time unless those people go on to teach others. And that's always the hope in medicine. But, is that something that happens or not? It's open from a time to time incidence. And then lastly, the committed partnership. So this is where all of these three things are happening on a continuous basis over time. And that's really how we see things grow and develop. And then the last tenet really is the surgery can be the easy part. Okay, so these are trays that we see, and if there's any surgeons on the call today, or students or trainees or anyone who's been in a surgical OR here in the United States, you'll see that the tray that's here is much smaller than anything that we use in the United States that I have personally been witness to. And so you really can kind of distill down to what the surgical rooms look like, what you're able to accomplish with less. And this is where it kind of drills down into the cost of healthcare. And, right now in the United States, we have a significant problem with cost of healthcare, and we're not alone. We're not the only country with that. And how do we, how could we maybe learn from our peers? It's not always about us teaching them. It's also about them teaching us. So again, kind of a three-pronged approach when I think about impact on a local community. One is research, two is clinical, three is advocacy. I'm really only going to talk about research today. That's what we have time for. But, you can come at global health or global neurosurgery or whatever your field of passion is within global health from any one of these three or all three or whatever portion is applicable to you and what drives your passion. And so really looking at research, Pediatric Hydrocephalus and Spina Bifida. When I think about setting up an international research program, there's really kind of 3 steps here overall. And this is how I did it in my setting, and hopefully it helps someone on the call today figure out what they want to do with theirs. So it's identifying goals, right? Obtaining resources in a team and learning the culture. So when we think about goals in Zambia, the burden of disease, right? We talked about this earlier, is high. Why is it high? And that's really where you get into the details of this. One is, what is the patient and provider knowledge about spina bifida and folic acid? How do we monitor the long-term outcomes of the kids in this region? And how do we educate the community about this problem such that it doesn't become a stigmatizing event? Next, really, these happen simultaneously, right, as a team, resources, and culture. So this is our team in Zambia, right? This is one of the maternity wards at the referring hospitals. We've got Dr. Humphrey Kunda is one of our, he's one of the neurosurgeons who on faculty at the University Teaching Hospital, which is the hospital that I partner with. And this is several members of our research team, Angela and Meshek. Research assistants, Dr. Tembo from neurology, and Dr. Malo, who's one of the first neonatologists in the country. And so this is something that this is the team, and we've added more members over time, but we've really grown in terms of nursing support, in terms of other providers involved and trainees and residents and so on and so forth. In addition to the team members, you need your resources, right? And so with this, we started this Care House of Hope in Zambia. And so Angela is the Chief Executive Officer and also a very dear friend and a research one of the lead research assistants on our team. And what we found with these is, right, a child is born with a disability, the child is born with a neural tube defect, they get referred to the major hospital. It's essentially the hospital who's able to provide neurosurgical care for these children as they need it. But the mothers would come and they would be in the NICU for a prolonged period of time. And so because of that, the mothers didn't have money to be able to have food, right? They're not fed as part of their experience there, as families typically will receive food. Who are placed in our hospital here at Iowa and potentially, I imagine, at Northwestern as well, and other hospitals around our country. And so they were sleeping on the streets. There was stories of prostitution to be able to pay for food for their child who was hospitalized, for themselves, for a place to stay. And so this Care House of Hope became a home. That really, the credit goes to Angela, but we work together to be able to help support this and make a home for these mothers while their children are hospitalized and while they learn to take care of a child with disabilities. And so this is something that this is a multi-pronged effort where it's shelter, but it's also become a hub for research projects, for support systems for mothers, and for generating that community. I will also say on the right, you can see a picture of the medical records department at UTH, right? It's very much a paper system. And so if you want to perform any research, it's got to be prospective. It's got to be from now until the future. So the Care House of Hope, again, this is a picture of some of the one time when we were there, and the mothers at the time who wanted to share a picture with us, is it really helps provide safe shelter. It provides a community in addition to an opportunity to help provide patient education. So going back to the goals that we were discussing, and so this is really looking at, we'll kind of go through these one by one, and that'll give kind of a broad overview of what are the active studies that we have going on in Zambia right now. So one is to understand the burden of disease in Zambia. So really with that, it's a needs assessment. So what we found with this is okay, there's delayed access to care. Most children born with myelomeningocele in the United States will present if their myelomeningocele, their neural tube defect hasn't been closed in utero, right, which is about 50%, I believe is the most recent data. About 50% of cases in the United States will go on to have in utero surgery, and 50% continue to have postnatal repair right now. In Zambia, it's all postnatal after the child is born. However, the first evaluation by a neurosurgeon, what we found is not till about 9 days of life, and these are averages. And then, myelomeningocele repair. So not only is the surgeon seeing the patient late, but the surgery is happening much later as well. I will say on average in the U.S. Is about, the child's evaluated on day of life 1 and has surgery on or before day of life 3. And so that's kind of a frame of reference of some of the delay that we're seeing. There's a high infection rate in Zambia. And so what we found really is about a quarter of all the myelomeningoceles, right, or spina bifida cases were infected. And that, as I showed you in the picture earlier, if there's no skin over the defect, if spinal fluid can leak out, does that mean the outside world bacteria can get in? Yes, that's the commonly held philosophy there. and there's a high complication rate. And so really, what's the incidence of spina bifida in Zambia? This is the public health study that really needs to be done. And this is something that we're actively working on right now and is a work in progress of if you're truly going to measure what the incidence of this is. We know based upon the educational outreach efforts we've done within the communities about spina bifida that many of these children are dying before they receive care. Whether it's because parents are not seeking care or because the child is just does not make it for transfer in time, remains to be seen, but we suspect it's a multifactorial reason. Goal number 2, to identify patient and provider knowledge about spina bifida and folate. And so this is a project that was just recently published, and it was something that was led by, I would say, I guess it was 3 years ago now when I was still completing my training at Vanderbilt, where we surveyed 61, Zambian caregivers of children with myelomeningocele. And what we were looking at with that is, what did the mothers, which caregivers in Zambia are typically the women in their culture, where are these people coming from? They're coming from all across the country, but the bulk are coming from around Lusaka, which is what the map illustrates. But what we see is, again, what we've linked is myelomeningocele, at least some cases are linked to folic acid deficiency, which some are aware of that, but many are not. And so what we're seeing is, in the United States, the typical practice, right, is if what healthcare is advised is if you're thinking about becoming pregnant as a woman, you need to be taking a prenatal vitamin before you become pregnant, right? Because that prenatal vitamin, one of the things it has within it is folic acid. So what we see in Zambia is there's not really a known, there wasn't known among the mothers of when to start their folic acid. And so this is something that what we found is that most women were starting it after they were already pregnant. And so with that, this is something that then becomes, we know that the neural tube, right, which the neural tube defect forms when the neural tube, which is, we're going back to embryology now, doesn't close all the way. And that happens within the first month of being pregnant. So if most women don't know if they're pregnant until it's a month in, right? And so it already is too late. If you weren't on folic acid already, starting folic acid at that point is typically not going to make an impact for that. What we're seeing is, again, this is what I was just illustrating here, is when you do start to come too late from a presentation standpoint with spina bifida, this is another example of a child's defect. You can see that this one doesn't have the pink component to it, right? And it's because it now has skin over it. So this was a child who didn't get neurosurgical repair, yet the child is clearly still alive, right? The child didn't get meningitis. And so this is something that opened up another Pandora's box of questions. But patients are starting to take folic acid too late. When things are addressed in a late fashion, maybe late's not always bad, which that's a controversial topic, but it's something to think about as far as, again, is there only one way to do it, or are there multiple ways to do it? With folic acid, we know that if you don't take folic acid before the neural tube closes, the folic acid isn't going to make any difference. And that was something, again, that we found here as part of the studies. Provider knowledge. And so this is something that Raya Mueller, who's one of actually Northwestern's medical students right now, and she may be here today, but essentially what the work that she partnered with our group in Zambia, as well as with Dr. Garcia, is looking at, so what are the impacts with provider knowledge? What are the reasons, what do providers know about spina bifida and delayed referrals? And so she and the team surveyed 123 different providers across 12 different sites across Zambia. And this included 69 mothers. And what they found really was that prenatal ultrasound was being done in the bulk of cases, right? Could it be improved? Absolutely. But only 4% of mothers reported a prenatal diagnosis, right? So as a neural tube defect, specifically myelomeningocele, is something that typically could be diagnosed on or after the 20-week ultrasound, right? The anatomy scan. So why is it that these women are receiving prenatal ultrasound? And I should have included on this slide prenatal ultrasound after 20 weeks gestation. So in theory, they would have been candidates, right? For that, if that was diagnosed, they would be aware of it. But only 4% are receiving the diagnosis. So why is this? What are the potential next steps here? Is it something that there's a subject to bias, right? So it's the mother's version of what she understood. And so is it something that she didn't understand and the diagnosis was actually conveyed? or not. So this has since been followed up with some studies that are ongoing right now about surveying the radiology practices across Zambia. And this, what we're finding is very interesting, that there's actually no problem with access to equipment, but it seems to be education and training. So looking at number 3, and this is the broad overarching study that we have going on right now, specifically looking at monitoring long-term surgical, urological, and neurological outcomes. So spina bifida is something that, again, the nerve roots at or below the level of the lesion are typically impacted. And so if it's typically a lumbosacral defect, so we typically would say, okay, there's problems with leg development, there's problems with bladder development, bowel development, and potentially, and what we know is, again, hydrocephalus is linked to it because of the spinal fluid dynamics and changes that occur with that. So what are the cognitive or neurological outcomes that come with it? So in neurosurgery, one of our governing groups is the Congress of Neurological Surgeons. And several years ago, they put together some recommendations about managing spina bifida, specifically myelomeningocele, from a surgical standpoint. And one of the questions that they raised, and this was, something that I've thought a lot about since, is, does timing of surgery matter? And so this is something that we started to craft together a team. What we found, right, what I was sharing earlier, is that in Zambia, the timing of neurosurgical care is delayed, right? It's 9 days is the first evaluation, and 21 days is the first surgical, is the average surgical date. In the United States, where we have it right now, it's typically, within 2 to 3 days. It's very similar across groups across our country. And the recommendations from the Congress was that, all spina bifida should be repaired within, I believe they said 48 hours. 48 to 72 is pretty standard. Is that something that is appropriate for example, a country like Zambia and a health system like Zambia, or is that not? And so what we wanted to know is, does the timing of surgery impact long-term outcomes? And so we assembled this group of providers across multiple different disciplines, and we designed a study. And so what we're looking at right now, the study's been going on for about 2 years now. We're looking at early surgery versus late surgery. And so early surgery was designated as less than 72 hours of being born, and late surgery as after that. And so far, we've enrolled 156 infants prospectively. Prior to this, I will say that I believe there was 1 or 2 infants in previous, cohorts that would have fit the early surgery window. So that the ability to get 26 early patients in Zambia is remarkable. Okay, and so this has been the result of a lot of education with referring doctors from the community, with mothers, with families. This is not a clinical trial. This is a prospective cohort study. And really with that is, if the child presents within 72 hours of life, the child is deemed safe to proceed with anesthesia through the typical standard of care at the University Teaching Hospital, we proceed. There's a ton of regulatory approvals that have gone in place to be able to do this. And so it's been very interesting to be able to, as we get close to concluding this study, our goal is 50 early patients. If we can try to reach that over the next year, to be able to reach our statistical power. And so we're hoping that will continue. The long-term outcomes that we're interested in, again, are the ones we talked about: brain development, bladder function, death, infection, hydrocephalus. So these are all things that are of interest. And stay tuned for the outcomes on that. Lastly, to educate the community about spina bifida, what we've learned in healthcare, right, is educate, educate, educate. Whether it's about prevention, whether it's about treatment, whether it's about red flag symptoms to talk about for patients when they leave the hospital or they leave their clinic, that they need to make sure that they're aware of before they call you, if they're worried something could be going on. And so in the world of spina bifida, that really revolves around folic acid, because that's what we know right now. There's a number of other things that we're looking at as a group as potential contributing factors to spina bifida. There's some studies out there that are looking at hydrocarbon exposure and, as they're linked to environmental pollutants. There's studies out there that are, we know that there are certain risk factors, like certain medications, that are no longer considered compatible with pregnancy, so on and so forth. So, public health and advocacy efforts have been very strong within the neurosurgical community within global health. And this is really a credit to many of our partners, some of whom who may be on the call today. This study was published by Nathan Schlowen, who I know is a former member of the Northwestern Feinberg community. He's a student, is now a neurosurgery resident. And really what he worked on was compiling, in 2021 at the time, was what is the state of folic acid fortification? We know it prevents 30% of cases of spina bifida on average, at least in the United States. And some studies that have been since replicated across other countries have shown similar data. What is the state of folic acid fortification across the world? And what you can see is actually, I thought was surprising to me, right? So there are a number, right? Look at Europe. There's a number of high income countries that don't fortify their food as a mandate. So why is that? And what is the thought there? And so I think this is something where, sometimes it's wheat, sometimes it's rice, sometimes it's maize. It depends on the diet locally, right? As far as guiding what is the best food to fortify. In the US, it's wheat. And so this is something that then became a folate working group. And you notice Zambia is not a country that fortifies. And so this is something that, I've been participating with and working with the surgeons locally as we continue to reevaluate that. What they're currently considering, at least as the last time that we discussed it, was potentially salt as a vehicle. Their maize is very common mode of common food intake by much of the community. But there's a lot of different producers of maize within Zambia. And so that's something to get all of them on board with. That is something that takes a very close and careful eye. So there was a big breakthrough that came in 2023. This was a big deal in the neurosurgical community, which is when the WHO and the World Health Assembly, its annual meeting, passed a new resolution to accelerate the efforts on food micronutrient fortification. And this was really the emphasis on folic acid is something that you should fortify and some mode of food that's appropriate for the country that you're in. And so this was important because it opens up different avenues for support within the global community if there's countries that are interested within fortifying their food. And so this is something that I'm very excited about. There were a number of neurosurgeons who worked a very long time to make this happen. So kudos to that group. So really kind of future directions and where we stand right now are these. There's a lot on this slide and we're not going to go over it other than what's in the red circle. So there's 3 buckets to think about this in. A lot of this is a credit to the Lancet, and this was something to think about as far as when you're thinking about a big problem, right? The problems can seem overwhelming. When we first moved to Zambia, it was like, where do we start? And how do we kind of break this down to a piece by piece effort? And I think within healthcare, this is a really good model. So looking at seeking care, right? So how does a patient recognize that they have a problem? So how do they know they have a diagnosis that they need to do something about? And then there's reaching care, right? So the patient knows that they have a diagnosis, but they can't get to the doctor to take care of them, right? They can't get to the specialist. They can't get to the neurosurgeon. How do you address that? And these are things, right, like ambulance transports, decentralizing neurosurgical care. So it's more easily accessible by the community. There's a number of different ways to think about that. And then lastly, how do you think about receiving care? So the patient recognized, they got the diagnosis. They made it to the doctor who's going to fix their myelomeningocele or their spinal defect. But how does that surgeon effectively deliver the care that they need to deliver, right? And this is where we start to talk about in-hospital-based issues or concerns or care. And so there's a number of different ways to do it. We wrote a paper that kind of outlined what our thoughts were at the time for that, but those are kind of the buckets that we try to break it down to within our group. So to kind of wrap up here, for trainees, if you're asking your question of how to start, my unsolicited advice with this is be flexible in your goals. What I initially thought I was going to do is not what ultimately necessarily happened. There is some overlap, but I think it's something that you really I learned along the way. I'm a very firm believer that everyone can learn from an international health experience. I think there's an incredibly strong program that you have at Northwestern and Feinberg, and I respect it greatly. At Iowa, at Carver, this is something that's also very robust in our College of Medicine and our international health tracks for students there. And I've been lucky enough to get partnered with many great students from that program. Number 3, I tell this to our neurosurgery residents a lot. Think twice about complaining. So I took a large chunk of the clinical portion of this talk out today, but there's a number of systems and creativities, and when we're moaning and groaning that we don't have the right instrument as a surgeon, or we don't have XYZ thing in an efficient fashion, I remind myself frequently that there's a lot of different ways to get this done, and so think twice about it could always be worse, right? It also could always be better. Number 4, get creative with research approaches. So how I didn't go into this too much today, but how I approach, this research experience is not because I knew that Zambia was my passion and that spina bifida was exactly what I wanted to study, right? I got connected with the global health community at Vanderbilt within the Global Health Institute there, who said, hey, I know, Doug Heimberg is a medicine doctor who I got connected with, who knew an infectious disease doctor, who knew a neurosurgeon. You'll find your way along the way. And then lastly, what is most important to you? Don't be deterred by roadblocks. So, I summarized it today, but there were a number of no's before there was a yes. And so this is something to keep after it. This is true for grant funding. This is true for, research. This is true for clinical or advocacy efforts overall. So with that, I'll say this is an example of a Zimbabwean roadblock that we faced one day. We were in our vehicle driving down the road, and I'll give you a time to think about how to get around that one. And then lastly, thanks to the team that works with me so closely. And I appreciate the opportunity to share today. So thanks, y'all. I appreciate it.
Roxana, you want to take it away with questions? There's a couple in the Q&A box.
Yeah, certainly. I'd just like to thank Dr. Reynolds for her time today. She's been an incredible inspiration for me as I've been undergoing my own career development, and I feel incredibly lucky to have intersected with her back in 2019. And I'm just so incredibly impressed by all the things that you've accomplished, Dr. Reynolds, in the short time that often seems long in our days of surgical practice and trying to balance an academic career. There are a couple questions in the chat, and I also have some that I can certainly add on, but we'll start with the questions in the chat. The first one is from Jonah Musa, who is asking, given your experience in Zambia and the making of quote unquote surgery simple, what is your opinion on promoting a resource-specific standard of care for surgical interventions and the benefits that global surgical experience will bring to the practice here in the United States?
I think that's a great question. And, resident education or trainee education is something that is not standardized right now. And I know there's a number of surgeons, and I can only speak to neurosurgery, that are working on this. So as we were showing with the maps, in the US, as I was talking about, the care of myelomeningocele has dramatically changed in the last 10 to 15 years since the big myelomeningocele, what we call the MOMS trial, the management of myelomeningocele study that was published. And we, made that advancement within surgery. But with that, our residents here in the United States are not as exposed, like they don't do as many spina bifida repairs now as they used to. And so postnatal versus in utero, now there's 2 different types to be able to do. And so in Zambia, right, myelomeningocele is something that you're very well versed in, and your education is ramped up very quickly as a junior resident, and you're very comfortable with that. So is there an opportunity to trade, right? Is there an opportunity to trade experiences, to be able to trade education with that? And do we have an ability to train our trainees there or their trainees here? Is there an opportunity for rotations or otherwise? And so I think that's one aspect of the question that was asked. The other aspect that was asked is standard of care. And this is where I think you have to be very careful. Yes, standard of care, we know protocols improve care, in general, right? There's surgical protocols, the timeout, antibiotic administration, but you have to be resource specific. And that was something that was mentioned in the question, but that can be highly variable from country to country. So you could say, I'm going to make a resource specific protocol for low and middle income countries. But even then, one low and middle income's difficulties is not what another low and middle income country's difficulties are. And so I think this is where it can get very nuanced and very challenging to accomplish. But I think there's value into it as far as setting standards and benchmarks.
Great. Thank you. The next question that we have is from Natasha Barahona. She says that she's currently completing her master's thesis in the field of global neurosurgery with Dr. Haglund at Duke. She'd like to know how you have leveraged and built relationships with lower level referring providers to get patients to neurologists or neurosurgeons earlier. And if you have experienced challenges with getting patients referred earlier, but not having the capacity to operate on them in a timely manner.
Yes. And so this is where it's become relationship building and a labor of love over time. So we've invested heavily in the Zambian team that's there full time, that we've taught research principles, ethical research practices, so on and so forth. And so then it becomes more of colleague peers teaching peers. And so this is where that model is set up, where it's not me going to the referring doctors, right? It's not necessarily even students that come to visit from here, right? This is Zambians teaching Zambians. And so this is something that has come through medical conferences with my local co-PI, Dr. Kunda, who's presenting at, the National Zambian Medical Association, who we have different rotating members of our team. I was mentioning her, like Dr. Mala, one of the neonatologists, goes on some of these trips too. And so it's a diverse group that's got varied interests. Sometimes one of our anesthesiologists goes. And so I think that really buy-in has come from creating the community. We also have a study phone. And so that's something where that's staffed 24/7 for any referrals to help expedite with the hospital system. Because as I said, with surgery, the water, the blood bank, the electricity, Zambia also has a lot of challenges with reliable electrical grid, with reliable cell towers. And so what we found is redundancy within the system has also helped quite a bit. And then with timely surgery, this is where that multidisciplinary team came in as well. So the chief of pediatric anesthesia, Dr. Chanda, is part of our team, and we brought in the pediatric anesthesia fellowship program to help staff these cases, because they're now deemed emergencies, right, to be done. That was what they needed to be done within 72 hours. And so there was a lot of the system built out that I'm happy to talk about more on one-on-one in any environment that she's in. But those are kind of the principles that we took, and it's really been the buy-in of the group that's helped this advance.
Yeah, I'd also say that, all the sensitivity site visits in the districts have probably helped support that. That is integral to all of the efforts that are ongoing within your 4 research aims have been really, really, I think, vital for people to be aware and also refer patients. And that's incredibly time intensive. When I was there in May, I participated in one visit, and we must have traveled the distance from here to Denver and visited 20 facilities in that time, doing a lot of discussion and question and answer, but also data collection. It seems really easy for Dr. Reynolds to talk about it, but it's incredibly time intensive, of all the activities that are undergoing. There's another question in the chat, Dr. Reynolds, from Elizabeth Chan, who says, excellent talk. Have you looked into the rehabilitation services these children have access to post-surgery or throughout life, if any are available? Have you looked into if providers there are trained, aware of complications to watch for as children grow with myelomeningocele, such as syrinx or tethered cord?
Great questions. So this is a brainchild that's in the making, actually, because equipment, right? Therapy equipment, everything has to be imported, to my knowledge right now. And this is something that is very expensive. And these mothers, I didn't go into it today, but as far as the average monthly income for women enrolled in our cohort is the equivalent of US $15 to $16, right? The average education of these women is about 70% have completed primary school or no school, right? And so this is something that we have a different setup among this group, but what these women do know very well is how to be a mother. And they're very creative in how to make, how to trade. And so at the House of Hope, we're working on building a program right now, which is an education program for the mothers who stay there, teaching them skills. And one of them is therapy equipment, because it's something you can build out of wood and string and tools that are available there. And so things like AFOs and things like shower chairs and things like, crutches are all things that you can build. And so this is actually becoming and working towards becoming a sustainability effort, and kind of goes back to what I was referring to with the man stuck in the hole versus teaching the man how to get out of the hole. And so this is something with, if you can do your own therapy equipment, you can sell that, you can make money. There's numbers of models of this around the world, right? With basket weaving, with what is that store? 10,000 Villages, I think. That is a store commonly in the mall that sells, things from people made around the world. That's very much there. As far as the second part of the question with syrinx and tethered cord, that currently isn't addressed there. And that's because that goes back to the MRI scanner. You have to typically have an MRI scanner to be able to diagnose syrinx, that's reliably accessible. With respect to tethered cord, it can be a symptomatic diagnosis, but part of that typically does involve some kind of neuraxis imaging before you would proceed for any intervention for that. So that remains a work in progress.
Great. Well, I thank everyone for their very thoughtful questions. I think I'll leave it at that just to respect time.
Yeah.
Dr. Murphy, if you want to make any concluding
Yeah,
comments.
just a couple remarks. Thank you, Roxana, and thank you very much, Rebecca, for joining us today. It was really an incredible presentation. I want to also thank the audience for joining us and for asking your very thoughtful questions. We invite you to join us at our next Institute for Global Health event, taking place virtually via Zoom on Wednesday, February 4th. Turning Evidence into Action, Advancing Youth Mental Health Across Africa will be presented by Amelia Van Pelt here, Assistant Professor in the Department of Medical Social Sciences and Center for Dissemination and Implementation Science, and Associate Director of Research at the Ryan Family Center for Global Primary Care here at the Institute. You can register via our newsletter, Planet Purple, and our social media pages. And we're actually like right on time, Rebecca. I think this is the first time we've actually been perfectly on time. Thank you for everyone
It's
for
the
joining us
neurosurgery way,
today.
Rob.
Yeah, it was bound to happen after, 100 times. A recording of the webinar will be available online and will be shared via our newsletter. And this concludes today's webinar exactly at the top of the hour. Thank
Perfect.
you very much.
Okay, thank you guys.
Take care.